Nice. Yep.
Welcome everyone to another RACGP Victoria free webinar. Tonight we have a presentation on the GP's role in aged care. This webinar is brought to you by the New Fellows Committee of the RACGP Victoria. My name is Dr. Imran Mazouk. I'm a member of the RACGP New Fellows Committee. I split my time between general practice 3 days a week in a clinic, and 2 days a week I visit 4 aged care facilities around the practice where I work. I also have an interest in skin cancer medicine and refugee health. Just a bit more about me. I previously trained as a radiation oncology registrar before switching careers to general practice. Finished a master's in public health, and I've lived and worked all over Australia. Outside the medical bubble, I'll give you a little bit about all our presenters tonight outside the medical bubble. I'm a part of a percussion group. We learn to play a variety of West African and Latin American and Sri Lankan drums. So I'll be facilitating the webinar tonight, and we'll ask our presenters as many questions as you like. I'll get the questions in as you ask them. I'd like a request that you put them in the typed format, and we'll put the questions to the presenters at the end. Before we start, I'd like to make an acknowledgement of country. We recognize the traditional custodians of the land and the sea on which we live and work. I will introduce you to our speakers shortly, and just also a reminder that all attendees tonight will be getting 3 RACGP QI and CPD points, as long as you watch till the end of the session. A short survey will be sent out tomorrow, and we'd appreciate if you would take a couple of minutes to answer those questions when they're sent out to you tomorrow to help us improve our services. The session is also being recorded, and it'll be uploaded onto the RACGP Victoria resources page, and you can watch it later at your leisure if you wish. But you would not get CPD points if you do it that way. A link will also be sent out to all attendees with the survey. So as I said, you can type your questions in as you go, but I'll collate them and put them to our presenters at the end because we have quite a few things to get through. So I will begin by introducing our first presenter. This is Narelle Gresh. Am I saying it right?
Yes, you are.
She's an RN and is currently the service manager at Arcadia Aged Care in Essendon. Narelle has worked previously in acute oncology. She is now in clinical management, and together there's been nearly 19 years of the combined experience before moving into aged care work about 10 years ago. She's worked in various roles, from being an RN on the floor through to her current role as the service manager at the nursing home. She has postgraduate qualifications in cancer nursing, palliative care, dementia care, and she draws upon her experience in all of this to lead her team of nurses and ENs and patient care attendants at the facility. Her interests include dementia and management of behavioral and psychological symptoms of dementia. She has an interest in care for the deteriorating resident, as well as depression and other mental health issues when people transition into aged care. One of her future career goals is to manage a care facility which is designed specifically for younger people and for those with early onset dementia. So I will hand on to Narelle shortly. The learning outcomes of this presentation, by the end of this, ideally we should have outlined the new standards for aged care, including the aged care funding instrument. We'll discuss common issues such as falls preventions, medication rationalization, and dementia in aged care, which will be covered by our geriatrician, Kelly Wright. We'll review different service models of aged care provision, which will be done by Dr. Sachin Patel, and I'll explain briefly the new MBS items and the application to aged care provision. So, Aged care is difficult. This is one of the lists that one of my patients gave me this week. She tried to get me to address all of them, and we did our best. And hopefully, by the end of this presentation tonight, we'll get to a point where it's not as overwhelming, and hopefully we can encourage you to keep doing what you're doing. And if you're interested in doing more of this work, we'll give you some tips on how to make it less challenging. So our first speaker is Narelle Gresh, and I'll hand over to her next.
Hi everyone, how are you? And thanks Imran for inviting me to attend this webinar. So as Imran said, I currently work in an aged care facility. It's a 103-bed facility, and I have 140 staff under my jurisdiction, for want of a better term. So I suppose there's a lot of hot topics in aged care at the moment, but certainly the transition to the new aged care standards is something that's presented some challenges for those of us working at site level. So just a bit of background. 1st of January 2019, the Aged Care Safety and Quality Commission was formed, which basically has incorporated the Australian Aged Care Quality Agency and the complaints component of that as well. And by January 2020, then there'll also be the regulatory functions of the Department of Health are all going to come under that umbrella. The reason that that's happening is to essentially streamline those services. It's very difficult working in aged care when we're not sure which regulatory body to resource, access, and certainly to pass our information and, you know, be it a complaint or be it a question onto. So how are they different? How are the aged care standards going to different? So currently we have, up until the next few days, we had 4 standards which we had to work to. We're now working to 8 standards. The previous system was very much focused on a systems and processes. Now that we're working towards a consumer-driven type of care, we're now more interested, or our standards reflect that we should have more of an interest in how people feel. And it's about teaching people, or about enabling people to have enough flexibility and to help them to choose the way they want to live. The demographic that I'm seeing in aged care, the people that are coming in are a lot more sassy. They know what they want. They're coming in and they want Wi-Fi and FaceTime and Facebook. And, you know, as consumers, they're well and truly entitled to that. And that's what we're looking at. They're also much more knowledgeable. A lot of the people I'm seeing are from professional backgrounds. And as I said earlier, they're a lot more empowered. So they demand a certain level of service. They're paying for that service and they expect to receive it. So the next point there is, what will facilities need to change? For us at Churches of Christ, nothing will change. We adopt in our organisation we call a positive wellbeing model. So essentially for us now, it's about making sure that we're ensuring the care has the consumer at the heart of it. And that it's got to be a collaborative approach to care. When I first started in nursing a few years ago, and even in aged care almost 10 years ago, it's pretty much we made all the decisions for the person about what we thought was best for them, based on best practice and based on our clinical knowledge in managing them medically. But now we need to look at the whole person, and now they need to have input. They're telling us what they want for their life and for their care. And agency visits. Agency visits are also a big part of what we do. My facility actually had an unannounced visit last week, which was very interesting. So all of our contact sites now are going to be unannounced. And in the past, an unannounced visit was one of those visits in between our full accreditations. So what that means is that when we're due for full accreditation every 3 years, which gives us now they're only issuing 2-year stints, we will submit a self-assessment and we'll apply to the agency to have an accreditation visit. And essentially when we push go on the button, they could turn up the next day. As a facility manager, and I know that sort of in the industry there are a lot of facility managers who find that quite daunting. For my way of speaking, I don't think we should be rolling out the red carpet and shining the brass knobs just because we know the agency are coming. It needs to be the norm. The care that we give needs to be of the same standard 365 days a year. So yes, it's a change, but for me, it's actually a welcome change. So ACFI, and in talking to Imran, this is quite the hot topic as well, especially amongst GPs, and understandably can be quite laborious in relation to documentation. And whilst I can understand some of the frustrations around that, certainly, hopefully I can shed a little bit of light here tonight on the reason we're asking you to do it. It's not to annoy you, it's not to make your day any more arduous, it's basically a requirement that we need. So what is ACFI? ACFI, the acronym there is the Aged Care Funding Instrument. And basically what it is it measures the level of care based on 3 domains, being ADLs, behaviour and complex. And the outcome of that assessment, and all the assessments we do over a 28-day period, determine what amount of subsidy we get from the Australian government. So what sort of subsidy is paid to the aged care providers. The amount of funding we get, if you can imagine somebody who is high, for instance, they're fairly intensive in the level of care that they need. So for us to be able to have some subsidy from the government to ensure that we support all of their needs, it's imperative that we get it right. We are actually validated and audited against it. So if we don't produce the evidence, we lose money. And I can tell you categorically that they don't hold, they don't hold back. If they see that there's not an evidence, it could be not dotting your I or crossing your T, they will drop the dollars, which has a big impact on us because it basically helps us to fund the staffing module that we have, which enables us to make sure that we're giving the level of care that these people need. So why do we require documentation from GPs? Essentially, a lot of the stuff that we are required to submit has to be validated. Things like depression, edema, anxiety, and dementia diagnosis. Those diagnoses can only be given by a medical practitioner. So we need to have evidence that they're documented, be it on a discharge plan from a hospital when they're transferred to us, be it from the GP, be it as a consequence of a geriatrician visit. We have to provide them evidence that that's been documented by a medical practitioner. Things like, we also, it goes really into the nitty gritty, but things like positional changes. We get extra funding for somebody who requires positional changes as part of their pressure care. As a registered nurse, I can provide that directive and documentation because that's within the scope of my practice. So when the nursing staff at the facility are asking you to document that this resident needs a blood pressure daily, weekly, or that they've got a depression diagnosis, that needs to be applied every 12 months, by the way. It's for a very valid reason. It's because we are required by the regulatory body, Department of Health and Ageing, to provide the evidence that supports the claim we're making to the government. So it's not something we take lightly, and it's certainly something that we need. It is going to change over the next 12 months, though. We at the facility will be responsible for doing all the care planning and the care for the resident, but one of the things that's on the table, and I've actually had some input into one of the drafts for the new funding model, is that the funding will actually be done by an external body. I'm not quite sure what that's going to look like. I'm not quite sure how that's going to work. And I'm not even sure that if somebody has a change in care needs, how we're going to then be able to apply for the extra funding. It's a grey area, and I guess the reason I mention it here tonight is pretty much what we have now is what we have, but watch this space. So continuity of care is something else that I think is really important. I think that it's really important, as I said there, well, why is it important for a facility and GP to have a good working relationship? Basically, the relationship needs to be built on a mutual trust professionally, and a mutual trust that we're all there for the right reasons. In essence, the nursing staff and the carers who are at the coalface and they're at the bedside, they're your eyes and ears. And it's really important for continuity of care and to make sure that we get the best outcomes for residents, that we establish a really good working relationship. It's difficult sometimes to get GPs into aged care because, it can be quite intensive and laborious from a documentation. You're dealing with the sickest people in our communities, the people who have the most comorbidities, the issues, the behaviours associated with their dementia, essentially all those challenging medical issues. And, you know, I've had some of my GPs say, well, why would I come into a facility when I can sit in my nice warm clinic and see, you know, some fairly straightforward people? I'm not saying that aged care is not challenging, but the only way forward for people living in aged care is to have good GPs who are committed to the cause. The other reason that it's important to have a good GP or to have GPs essentially working is that we can be really responsive really quickly. I know in my facility, sometimes I'll ring a GP and we notice as nurses, we see these people every day, the subtle nuances and the changes in their condition. We can be onto it early. It produces a really good outcome for the resident and for the family for that matter, because all they want is that, you know, their loved one gets the best care possible. And again, I suppose that goes back to our new standards, and that's about the consumer being at the centre of everything that we do. So qualifications and skill sets of staff in aged care, I can only speak for what happens in my facility. I know that it varies across. I do think that things are slowly changing in relation to that. In my facility, I have a registered nurse in the building 24/7. I don't have I'm a registered nurse myself, of course, but I don't have registered nurses on calls because, again, they need to be there. The residents need to be assessed and decisions need to be made. In relation to medication management, all of my medications are delivered by endorsed enrolled nurses and registered nurses, and the carers are there to provide the bedside care. No aspersions cast on facilities who have carers delivering medications, but I suppose as the manager of my facility, I really want my nurses to understand the consequences or understand the complications of the medications that they're giving, the side effects, and not just be counting medications and giving pills. And so that's my rationale for my staffing module. All of my staff that work there usually come from an acute care background. Unfortunately, in this industry, and certainly when I started my nursing, nurses who worked in aged care were considered to be the dregs of society, the ones that couldn't make it in acute care. I can categorically say that that's not the case, that a lot of my nurses are very senior and have really grassroots nursing assessment, which is what required, because I've worked in acute hospitals, and unlike hospitals, we don't have a resident or a registrar sitting in a desk space, and we don't have oxygen on the walls and stuff. We have oxygen and suction and everything available, but it's a very different setup. It's very much, in a sense, I've likened it to almost like remote or rural nursing in many ways. So I suppose that also goes back to my point about having a GP who's accessible and available and responsive, because we get good staff into aged care and you can be well assured that the assessments will be spot on as well. In aged care, we also utilise a lot of other services. Locum services are absolutely fantastic. They're really good there for a shortfall, but my fallback is that the primary doctor should always be your first point of call. It's really important, again, back to that continuity of care. Our philosophy of care is that my facility, we call it home. It's never going to be home, but the reality is it's their home. It's their last, you know, God's waiting room is what some people have called it. So we do everything we can to keep our residents in our facility. So not foregoing a fall and a fracture where there's no option but to hospitalise. We do everything we can to keep our residents in the facility. We work really closely with the Royal Melbourne Hospital here in Melbourne and their InReach program. So that's access to, rather than putting somebody on a trolley in an emergency department cold and what have you for hours, the emergency department comes to us. We have a triage nurse who then liaises with a registrar or a geriatrician in relation to the care of that person, and they then just pass over to hospital in the home. So we can do things like IV antibiotics in the home. We can do, you know, we have a doctor coming every day and they're technically in hospital, so the GP actually isn't involved in their care. They're certainly kept in the loop by way of communication. But it's not unlike them being in hospital. You wouldn't go in and visit your patients in hospital. So the care is taken over by the hospital in the home, and it just means that we can keep people at home in an environment that they know, with staff that they know. Throwing in a dementia diagnosis, it really makes their recovery so much quicker because nothing is changing for them. Residents who have dementia, basically, they don't fare well in hospitals because it's not geared to their specific needs. One of the things I'd love to see in my facility, which we've been talking about for a while, is telehealth. I'm really a big advocate for that. I think that, again, back to a resident's right to choose and their dignity of choice, going out to appointments with specialists like cardiologists or renal physicians, geriatricians, anything like that, to be able to provide that service for them in their home and still empower them with the information to make decisions about their care and their life and their future and what direction they want to take is absolutely imperative. So that's something that I really would like to see in my facility, and that is a work in progress. So palliative care versus end-of-life care. This is another thing that I think is really sometimes challenging for GPs, and if it's not, things aren't communicated or you don't have a good working relationship with the team in the facility, it can make this part of the journey really, really challenging. One of the first questions I get asked by prospective clients on a tour is, do you need to send them to hospital to do palliative care? Can you do palliative care here? My response is obviously no. It's the whole package here, and having had many years background in palliative care myself in an acute setting, then I very much believe that there's no reason why people can't be palliated in their homes, our home, their last place. So some of the things, all of my residents, I've got 103 residents, as I said earlier, and I can tell you that all of those are being palliated. So there's nobody in my facility who's going to be discharged home to carry on with their life. They're all palliative. In deference to end-of-life care, which that I term in as the last 7 days of their life, 7 to 10 days. We use end-of-life care pathways, and it's okay to come off an end-of-life care pathway. I think some of my staff originally thought, oh, once you go on the pathway, that's it, you have to die. There's no going back, and how dare you not? But some people rally and they can come off the pathway, so that's okay. The things that help us with ensuring that we are fulfilling the wishes of residents in our facility is advanced care planning. So our residents are given an advanced care plan on admission, and we explain that to them as it's not a legal document, it's just a living document, so that we know when that time comes, when that end of life care time comes, what is acceptable to you, what is not acceptable to you. And there's also some information there around some of the things that they would perhaps like, do you want dolphin music playing? Do you want a three orchestra band? Do you want your family there, or would you rather they stayed away? Those sorts of information. The other thing, again, which goes back to making sure that you're working with a really good team, is anticipatory orders. So there's nothing worse than getting that call, somebody's had a sudden change in health, we've looked at their advanced care plan, the family are all on board, and we're now at the stage where we need to implement end-of-life care. Most facilities who know their residents well will know when people are getting closer, and it's about GPs trusting the nursing staff that if they provide an anticipatory order of some morphine, some Buscopan, maybe some Maxilon, and maybe a bit of Rivotril or something like that, that the nurses that they're working with are not going to just use that willy-nilly, that it's there for the purpose of palliating the person if that comes. And we've all had residents who have deteriorated really quickly and are needing that symptom control at end of life care, and that's really, really important to have that there and have it on hand. And again, that just goes back to, I suppose, to the next point about dying with dignity, but also dying at home as well. And the other thing I think that is really important for GPs and facilities to be able to liaise well with is to be really clear and transparent about appropriate interventions, what's appropriate and not appropriate, not necessarily to us, but to the person who we're talking about. And again, that goes back to the consumer's right to live and die the way that they choose, which again is incorporated in our new standards as well, and making sure that any interventions we're doing are appropriate and that it's always a collaborative approach. So I suppose just my last point on that is that as arduous and as annoying at times as it is, when I first started nursing, basically the ethos was if it's not written, it's not done. And that's pretty much how it is in aged care. And it really is important to document. And, providing the facility has a process in place so as, not to take up GP's time unnecessarily, then it should really run smoothly. And I suppose it's important for me to make sure that you realise that anything that we are asking you to document, it's for a very valid reason, either because we require it from our regulatory bodies or for the purpose of our funding. So that's probably all I have to add. Thank you.
Thank you very much, Narelle. That was great. We'll now change presenters. Next up is Dr. Kelly Wright, who is a geriatrician that works in various parts of Melbourne. She predominantly works in private practice, and she also has an appointment with the Monash Alfred Psychiatry Research Centre at their Caulfield Dementia Trials Unit. Kelly undertook medical training at the University of Queensland and residency in North Queensland before moving to Victoria, where she completed physician's training at St Vincent's Hospital. Kelly manages all varieties of geriatric syndromes, but has an interest in memory and the treatment of dementia, as well as helping people maintain their independence. For residents in aged care facilities, she prefers to visit them in their own environment, saving the trip to her consulting rooms, which are in Malvern, Moorabbin, Belfield, Sunbury, maybe a few others as well. She's all over the place. I don't know how she does it. She balances her work with all of the aged care work that she does, along with being a mother of 4 young boys, including twins. Her whole family are keen runners, and she's working towards a second half marathon. Kelly also volunteers for the local Multiple Births Association, offering support to young mothers trying to cope with the joys and challenges of having twins. Now I'll hand over to Kelly. She will cover some commonly found geriatric syndromes and issues that we often come across in the nursing home setting.
Thanks. So aged care from a geriatrician perspective is a huge topic, but I was just hoping to talk a little bit about some of these main areas, and happy to deal with any questions after the webinar as well as during the webinar as needed. So falls is a big one, and a lot of people just contribute it to old age, not doctors of course, but families and residents, and there's a lot we can do to look at prevention and strategies. So we're going to look at that tonight, as well as the osteoporosis management that goes with falls. Medication rationale is very important as people get older. Do they need all those medications? And the main complaint I hear from people is, I rattle too much, doctor. Can you get rid of some of these pills? In aged care facilities, a lot of the time I get called in would be because of the challenges of behaviours that can occur with dementia. And just a brief mention about the changes in advanced care planning that's happened in Victoria just in just over the last year. So as everyone's aware, everyone's getting a bit older in terms of our population, and we're using residential care even more. So this is just from the statistics showing that it's sort of, just increasing a little bit there. And who is in care? Looking at the stats, 40% have this diagnosed frailty, which is the buzzword in the last 5 years. They're more than 85 years old, mostly women. 90% will have a physical disability, and 75% will have a psychosocial disability. 50% will have a diagnosis of dementia. 49% will have depression. And on average, people can be in permanent care for up to 2.5 years of their life. And that can be as little as a month, but it can be as much as a few years on top of that. So looking at falls, it's quite important because it's the 6th leading cause of death. And if you're out in the community, your rate of fracturing and needing hospitalisation from your fall is only 5%. Whereas if you're in a residential facility, that increases quite substantially based on the demographics of who's in care. After a fall, 50% have a fear of falling, which then restricts their mobility, and they can easily become bedbound because they're just so fearful. And 25% of those won't get back to their active status. So what can we do? I like the suggestion of wrapping them in cotton wool, but I don't think we can do that. So I guess one thing to look at would be, why or where are people falling in a facility overall? Is there a particular location? Could it be a slippery floor? Could it be the time of day everyone wants to use the bathroom after they've had their meal? So looking at that and seeing if the facility can adapt to try and decrease falls. Medically, it's good to look at the intrinsic, extrinsic and behavioural factors, which we'll go into more detail. The idea is to try and keep people mobile and to build up their confidence and try and get them back to the standard of mobility that they were at before the fall. Blood pressure review I find is very satisfactory, because if I find someone with a low blood pressure and stop those blood pressure tablets, often that can decrease the falls risk, and then I feel good because I've done something. Hip protectors is quite popular in terms of trying to prevent people fracturing their hips if they're falling. Of course, residents don't always like to wear them, and continence is always an issue. But there is evidence that if they do fall, it does decrease the rate of fracturing, but of course doesn't decrease your falls rate. And then in facilities, they'll have their own strategies, such as looking at the type of mattress people are on, lowering the bed down to the ground, and using sensor mats and buzzers. And also lots of information signs that I've seen sticked up on wards. Use the buzzer in front of where people sit. So intrinsically, from a medical perspective, I think we can do a lot here, looking at what is causing that fall. And some of it's age-related and we can't do anything about, but sometimes we can look at that disease and optimise things and change those factors and decrease that falls risk. Vision is an important one, and people have different vision in terms of where they can see, and whether that's problems with their periphery and therefore down low and they, tripping hazards in their room, or whether it might be more their central vision. So having a think about their vision and whether we can modify their environment to adapt to that is always useful. And extrinsically, we have lots of medications that can increase people's falls risk, as well as environmentally, just looking at the stairs. As you get older, your contrast changes, and so looking at something that's the same colour, like the stairs there, people will miss that there is actually a difference in the depth there, whereas colouring the side bits of the stairs can change that quite a lot. And mobility aids are great to decrease falls risk per se, but they also are involved in falls a lot, just being in the way or tipping or tripping on them. So it's a pro and a con whenever we use mobility aids. And then I guess we can't really deal for everyone's behaviours and what they want to do, and everyone has a right to what they want to do, but I guess it's trying to educate people and ask them to ask for help rather than trying to do it all alone. Osteoporosis is big because as we're getting older, the rates are increasing, and it seems to be quite topical in terms of what sort of treatment we should be initiating, especially with the denosumab coming on board. So I find this one that we have to tailor to the individual, and first things would be to look at their prognosis. If someone's got a prognosis of only 6 to 12 months, then in terms of decreasing their osteoporotic risk by treatment is going to be quite tricky. We do have the FRAX scores to take into account their percentage of fracturing over 5-10 years to help with us, but I think it's also looking at their current versus initiating treatment. If someone's on a current treatment, how long have they been on it? Has it been beneficial? Is it still doing its job? So that one's probably a different conversation to the initiating treatment, because a lot of people will fall, fracture their hip, and that's the pivotal moment when they enter into residential care. And so hospitals may treat the hip and forget about that osteoporotic treatment, and it's the GP seeing them for the first time in the facility who will be having to think about, what do I initiate? Is this the right thing for this person? So looking at that treatment for that person. Diet and exercise, so trying to stay mobile is good for staying active. Diet-wise, that's a bit tricky because everyone's on the facility diet, and more it's about quality of life, but also trying to encourage calcium in the diet is important. In mobility, a lot of people will say, well, that we don't need to worry about that osteoporotic risk because they're not mobile, therefore they're not a falls risk. But there's a lot of, people can fall out of chairs, they can be a bit impulsive and roll out of beds. If the bed's not down to the ground, they may hurt themselves. And also just not being mobile increases your osteoporotic risk. So people then having to be in a sling hoist, I've seen someone fracture just because of their porous bones. So just, I guess, putting that into the equation of do they still need some treatment? Is it worthwhile treating? Vitamin D screening can be controversial. I think everyone in the southern states is deficient in vitamin D, and it's probably just worthwhile putting everyone on vitamin D. But then comes the question, do we have to load them because they're so low with the 3,000 units a day for a month and then drop them back to the maintenance, or do we just presume that they're low, especially in winter, and just get in there and do it, or order the blood test and treat off that? So everyone's got their own preference for that. And also, I guess, the level in terms of what are you aiming for? Are you aiming for a level of 50 on blood tests, or are you aiming for 75? I guess, to me, the more the merrier in terms of vitamin D. But then, we all thought, great, we've got these, once a month treatment for vitamin D, once a week. And then now we know that's not the right way to go for people as well. So back to the daily dosing, I think, for vitamin D. And calcium, we put everyone on calcium, good for the bones, but we've got that link with the cardiovascular risk increasing. So in geriatric land, I think what most of us do in practice is if someone's already on osteoporotic treatment, like your bisphosphonates or Prolia, all of those trials were done where people were taking those supplements, and we don't actually know what happens if we're not giving those supplements. So we will continue the calcium and the vitamin D because it's also being pulled into the bones and out of your serum, decreasing, I think, the risk of it going around and causing that cardiovascular risk increase. Whereas if I have someone who is osteopenic or normal, I would stop their calcium supplements and just have them on vitamin D. Bisphosphonates, they take up more time. You have to do all the sitting up first thing in the morning, so that can take staffing time as well as the patient or the resident's time as well. And a lot of the time when you actually question people about maybe not in facilities where they're actually getting the medications, but if you question community people, it's the bisphosphonates that a lot of people are not compliant with, and we know that, and yet we still prescribe bisphosphonates and hope that people take it. So I was really excited when denosumab came onto the market, and we've got some good data now going out that there is some safety involved there. It still has its problems, of course, but it is a good alternative, and it's once every 6 months. The problem though is the stopping of the denosumab. As soon as you stop it, there's that increased spike of increased risk of fracture, which makes it difficult in a facility because that's when we're thinking about should we or shouldn't be on treatment. So it is important if we are stopping that, thinking about their prognosis and adding in a bisphosphonate in that acute time when they're at increased risk. And then once we've been on the bisphosphonate for a while, stop that. Whereas with the bisphosphonates, people are having drug holidays as well. So do they still need the bisphosphonate if they've been on it for the last 5 to 10 years is another consideration, as well as the renal function. So it's good debates you can have about what would be good for people. In geriatrics, it's quite an unusual group in that we can have some people who are young in age, but actually from a lifestyle way, they actually look like they're 90. And on the other hand, you can probably have some very healthy 80, 90-year-olds on no medication, and I guess we don't really see them except at the supermarkets. So it's very tailor specific in terms of who this individual is and what medications they should be on. So for medication rationale, there is a few criteria that people like to use. There's lots of apps that people are starting to use to try and work out which medication do these people need, which ones can I decrease or stop completely. There are some nice algorithms. I like the deprescribing.org, which has some guidelines and flowcharts on the statins, the protein pump inhibitors, the benzos, the antipsychotics, and unfortunate from geriatrics, it's got our cognitive enhancers that we like. But it is good because it's getting people to consider, do they still need it? It's not saying that we can't prescribe them, which is good, otherwise I'll be out of business. And the one that a lot of people might find tricky and get called about is the behaviours that come with dementia and what can we do from a medication point of view. I put this slide up because I wanted to remind us of all those non-aggressive behaviours that can be associated with dementia that we just don't hear about, but we should be thinking about. People who are so anxious, so sad, depressed, ones complaining about lots of psychosomatic complaints, and just putting worth that this is a behaviour that we should take seriously and what can we do about it, and acknowledging it as well for the individual. And then, of course, you've got all the aggressive ones, agitated, pacing, calling out, and it is challenging. And it's challenging because we don't have any magic answers from a medical point of view. A lot of it comes down to that non-pharmacological interventions, environment, who is this person, and working with the staff and trying to see what can change to try and help this person and make it less stressful for the individual. So it's always important just to take that first step back, just to look at who is this person, like someone who's up running around, entering someone's room at 3 in the morning, who turns out to be the milkman in his former life. Is I think, okay, now I understand the behaviour. What can we do about addressing this behaviour? So it is getting to know that person, which I do find in facilities, there's always that introductory summary about a person, what do they do, what's their family culture like, which I find helpful. And so there's a big list for people to look at and just consider each time they see people and see if there's something there that you could offer that someone mightn't have thought about. And then you've always got the dementia support unit who can also look at other features, and they've got more time to come in and work one-on-one with facilities and try and work out what is the best intervention for this person, because they've got that staffing time and can interact with people. So it is important to remember about that support that's out there. But if we were going to try some pharmacological interventions, there's lots that we can try, and everyone's a little bit different as to what works. I've got a typo there, it's the cholinesterase inhibitors. So your Ariceps, Exelon patches, they can help decrease agitation in dementia, but also your memantine can help a lot with pacing and just being constantly restless. Had some good outcomes with that. You've got this Telegram, which is quite handy, help people with their mood, but also is recommended in terms of EPSD. I find mirtazapine good for anxiety and sleeping, also stimulate appetite, because a lot of people have problems with weight when they're in a facility, or maybe a lot of people that I see are more 40 kilos rather than 100 kilos, just from the population that I see. The mood stabilizers, this one I find can be beneficial, but also it could depend on which one. Like someone might respond well to valproate, whereas others might respond to the carbamazepine. And it's about starting low and going slow and not going too high as well. If you're going too high in any of these medications, it's not the right medication for the person, and it's time to backpedal, wean it off, try something new. Pain, if I've got a pain, I'm a I'm grumpy. So looking to see if there's any non-verbal clues about pain that can be treated, or even just trying a Norsepen patch. I know the Dementia Support Unit use a lot of Norsepen patches just as a trial, just to see if that helps. Are they constipated, urinary retention, so just palpating their abdomen, see if there's a reason there. And then we've got the antipsychotics, and then just reviewing that, whether it's been helpful or not, and try not to keep people on it long term. And also just a mention about risperidone, because I see some people who've been on risperidone for a long time and they've got those extrapyramidal side effects, and so remembering to swap them over to olanzapine or Seroquel if you do need something long term, otherwise they'll start falling. And just quickly on the medical decision treatment maker, which is new as of last year in March, which has changed. So sorry for other states, but this is Victoria. But every state has its hierarchies and people to consult in terms of making those medical decisions. And Victoria's just caught up with the advanced health directives, which we now have to know about, and it's a legal document, whereas before we didn't have that. We just had people's wishes that we could consider. There's lots of resources to help people with those conversations, lots of different websites. So I won't say too much about that, and this is just our hierarchy in Victoria, just to be mindful of, and to just document your conversations if you're changing anything major in someone's medications, like adding in antipsychotics. And I think that's me. Sorry, I'll move that one across.
Thank you very much, Kelly. There were quite a few questions that came in, but we'll come to some of them at the end once we get through the next two presentations. Our next speaker is Dr. Sachin Patel, who some of you may know from other walks of life. He has many hats. Sachin was born and raised and trained as a GP in the UK. He moved to Australia in 2008 with his wife and fell in love with the place. They decided to make it their new home. Since then, he built and grew 2 large medical practices that were renowned for being very outstanding places for GPs to work. This is something I didn't know about Sachin. He actually worked as a personal care assistant in a nursing home back through medical school, and he always had an affinity for residents of aged care facilities as a result of that. He decided a few years ago it was time to tackle the challenge of providing general practice in an aged care setting, and so the company Aged Care GP was founded in 2014. Through all manner of challenges, he has put together a team that strives to improve the way general practice is delivered to residents of aged care facilities. Sachin's professional focus is firmly upon creating better experiences for fellow doctors, to harness the collective intelligence of the team to solve problems and believe strongly in having fun along the way. I'll now hand over to Sachin to give us a few examples of different models of general practice care, and then also talk about his model. But a conflict of interest, I would like to declare that I work with Sachin, and so we will try to not just talk about the way we do things, but also ways that other GPs out there are doing things.
Cool. Cheers, Imran. Good evening, everyone. Probably just a question before we get started. Tell me this, if you can, I think you can type in the questions box. If you already work in aged care, just type yes, work in aged care. If you're considering working in aged care, type maybe. And if you're already in aged care, working in aged care as a GP and pulling your hair out and you want out, type out. Excellent. It'll just be interesting to see what's coming through.
So we've got probably 75% of respondents saying yes, they currently work in aged care. Probably about 5% saying they're not working in aged care, and the rest, probably 10% or 15% saying maybe.
Okay, excellent. So I suppose when thinking about working in aged care. Let's make aged care great again, in the words of Donald Trump. That's what he meant when he was talking about making something great again. What are the problems? So at the moment, I think there's quite a narrative, and the narrative is that aged care is difficult, tough for GPs, no fun, just a headache, inadequate remuneration, not paid well. You hear that on online forums. You hear that from professional bodies such as the AMA. Then there's, and Narelle alluded to this, the perception that perhaps the workforce is de-skilled and not fit for purpose, when actually perhaps that may be just misunderstanding of each other, and what is perceived as a de-skilled workforce may just be people who are having to fulfill their regulatory obligations that we may not have a clear understanding of. And then it can feel a bit like we're carrying all the risk as a GP. You have to document X, you have to document Y, and you're a bit like this couple here riding the motorcycle on the high wire, and you just feel it could fall off at any moment. And all of that can lead to this feeling of just being burnt out when you work in aged care. However, when you get it right, it can be quite different. It can feel organized and smooth. Things seem to work. And then, just like this hand car, you know when to push and when to pull, as do your colleagues in the facilities and other members of your team, and things just seem to work in concert to get this vehicle moving along the track. And actually, it can be a good source of income for general practice if organized correctly. I know with people that I've seen in terms of their earnings, they can match or exceed traditional general practice if they've organized it well. And all of that together can lead to a feeling of satisfaction and fulfillment, of making a difference and doing the right thing. So I suppose just before I go on to talking about the five models that I can identify, maybe it'll be good just for a point of reflection for those of you that are watching and listening at home, just to type in if any of those feelings, I've just described 8 different feelings, if any of those chime with you, just type them in. I have to make you do some work to keep you awake and alive during the evening. Cool.
Burnout, satisfaction.
So a bit of burnout and satisfaction, excellent. Not excellent about the burnout, but thank you for replying.
Poor remuneration.
Okay, poor remuneration. I think that's a common theme, and perhaps we'll go some way to showing you where that feeling can come from.
Some GPs like the flexibility of the work.
Yeah, absolutely flexible. When you do a lot of aged care work, you're not going to have difficulty reaching your 10,000 steps either. Probably a bit healthier than being in a consulting room the whole time. So it definitely has its merits. So let's talk about, as I've divided the models into 5 main types of model. So first of all, you've got what I call the car boot. So that's the GP who literally does everything themselves. And it's great, right? It's flexible. You call the shots. There's no one to answer to. And that's great, but then things can get a bit overwhelming. And just like the capsicums tipping out of the boot here, we can start to drop things. And there are issues here that can arise around governance. So governance is concerned because we all do better when we have peers observing and reflecting back to us. And when we're not involved with peers, it can be quite easy to lose track of governance and actually just struggle to cope. And the types of things that we've come across in our journey through my organisation is we've recently taken over maybe 100 residents of one facility where, whilst they had a single named GP, which I think is too many in one facility, but they hadn't actually been seen physically, as far as we could tell from notes, for months. Although you know, drug charts and things had been done, so people were being managed by paper but not really managed clinically. And I suspect that that clinician was just overwhelmed with their work because they were working in this sort of car boot model. So a question for you: who recognises this computer? If you recognise it, type it in, and I will, for the first 3 people that can answer this correctly, I will send you a bottle of wine. What is the game they are playing?
I've got answers saying that Atari 2600. No. Commodore 64. 3 answers for Commodore 64.
Okay, it's Amstrad CPC 464. And the game, if 2 people get the game, I'll give the answer at the end. So I said 3 people, right? So 3 people, up to 3 bottles of wine coming. The other model you'll hear is about billing support. So when you look on online forums again, people will say, you know, why are you paying your practice a service fee of 30, 35, 40% when you could just set up your own thing or get someone else to just charge you 3% or 5% or 10%. And they'll do your billing on a computer like these people, maybe something a bit more modern. Although this is probably what Medicare still uses. Sorry. Why not do that? And yes, why not do that? It's a bit like the car boot side, but this time there's a little bit more support around the billing. So again, you know, can be quite appealing. You retain a larger proportion of the revenue you generate, but again carries the concerns and risks around governance, keeping up to date, having peer support, all of those types of things. And so, and although, you know, keeping 90 or 95% sounds great, actually, once you factor in the lack of efficiency in the way you may go about your work, the end result often will actually be that the total income part will be less, in addition to often the level of service you may be able to provide to the people that we're privileged to look after. So that is the billing support model. Then there's traditional general practice. So this is where you would often combine visits to an aged care facility with working in the traditional general practice, and that will often be places, facilities that are located relatively close to where your general practice is. Again, has merits because again here you're more in a peer group, and so you know, there is a bit more governance involved here, and you often have other team members involved, like an admin support team and some nursing support. So this is a potentially valid model. The difficulties here can be around, I know I was in this position when I used to merge it with general practice, is often, and I think if we're honest, lots of us may have felt this, you know, you get to the facility and the first thing you're looking at is your watch. I need to get back to the practice before my next session starts because there's going to be people waiting. So, you know, type something in, you know, type a yes if you felt that before. And you may know that inside, actually, we may not have perhaps given the best service we could have because of time pressures. So that tends to be one little drawback, and the other drawback in this model can be around annual leave coverage. Often there may be 1 or 2 doctors in a practice that are happy to go to aged care, but your colleagues may often not be happy to go, so leave coverage can be an issue. And as Narelle said, you know, there are other services that can step in to help in those situations, but facilities often like the relationship with the regular GP because they know the patient better and they know the facility better. Then there's some newer models. So there are newer models that are very centered on on provision of services to aged care. So some examples are services such as Hall or Genwise or lifelong healthcare. They're all examples of services that are a bit more tailored for aged care. And I think this is moving in the direction of where we need to be, sort of specialised, focused on aged care, because it has actually, over recent times, become its own subspecialty, separate to traditional general practice, and I think it needs to be just the resources, the acuity of the residents, the documentary and regulatory requirements for facilities that are ever increasing, the support required and the time required to offer that is requires dedicated specialised services. So the newer models are good. And then what I'd like to share with you is what I call the ACGP blueprint. So it's my creation, the way I've gone about looking at this problem. So you'll have to put up with my drawing and looking at me maybe. So I apologise in advance for that. But let's see if this works. We'll get a camera on. I can get probably everyone can see the board, I'm assuming. Just type a yes if you can see the board. Everyone's run away now because they have to put up with me drawing. But let's go for it.
Yes.
Yeah, cool. So, and get a pen and paper. So if you're watching this, get a pen and paper and maybe draw this down because I think this will be valuable for you. So if we want success and sustainable, so the S is for success and sustainable general practice work in aged care, then I think we need three things. Three things. I'm trying to work out where the camera is. There it is. And those three things are a clinical team, probably GPs with you. Then we need some admin and some nursing. When we have admin and clinical, you're doing less admin so you can have more impact on your patients. When we have nursing and clinical, your own work with nursing support, it increases your income. And when you've got admin and nursing support, you then have the ability to grow yourself professionally because you've got space in your schedule to do that, hopefully. Now, when you have clinical and admin, but you have no nursing, that often leads to no income or low income. When you have admin and nursing, but no colleagues, that leads to no collegiality. It can be a lonely existence. And then when you have clinical and nursing, but no admin, it means no time, because your time is spent doing administrative stuff. So, are you with me so far? Type a yes if you're with me so far.
Yes.
Cool. So it goes a bit deeper.
Couple of no's.
Okay. Cool. Hopefully it'll become a bit clearer. So it's not quite as simple as I've said. There's a bit more to it. So from a clinical perspective, I think for success and sustainability, you need peer support. I'll write peer in there. Then we need some continuing professional education, which comes hand in hand with your work, not just relying on external sources. And then governance. And governance can mean all sorts of stuff, but risk management is really important. Say you're looking after 100 patients, how can you be sure every time that you're not missing seeing patients on a regular set schedule? It can be very easy for patients to go missing and you to not realise if you don't have the right governance measures in place. And that's just one example. Then in terms of the nursing side, we need obviously stuff like health assessments and care plan reviews, things like that done. We need a bit of triage, otherwise we become the triage. And then a bit of help on a day-to-day basis, in addition to that provided by the facility teams. And then from an admin perspective, we need three things. So front office, which means, you know, taking phone calls for you, approaching your billing inquiries, those types of things. Then back office, helping you deal with things that unfortunately do happen, complaints, relationships with aged care facilities, that type of thing. And then we need effectiveness. And that comes from things like, and I can only give you a snapshot in this short time, but things like optimizing your workflow, marketing, helping you grow your patient base when you want to in certain places that you want to, making sure you're getting and able to provide the best for the residents that you're looking after in terms of making sure advanced care directives and other elements like that are carried out effectively. So once you have those 9 pieces, you probably need to wrap it in a couple of things. One is just being part of something, so probably a bit of culture, and then the other is technology. So because of the remote working nature of working in aged care, it can be very time consuming with duplication of notes, getting access to the right IT services, those types of things. So they're the 9 areas that I think are really important. How are we running for time?
Another 5 minutes.
5 minutes, cool. So we might just do a little exercise if you can. This will take 1 minute, maybe 1.5. So let's think of a traffic light system. Green, which means things are awesome. Amber means a bit sticky. And red means I'm really stuck. If you're already working in aged care, just do me a favor and mark each of these areas, the 9 areas, as green, amber, red. So green is I've got really good peer support. I know where to turn when I need a friendly ear. Amber is not really sure where to turn. Red is I just haven't got anyone. Same with education. Same with governance. You know, governance got really clear procedures around the way my risk management, the way my clinical governance is. Amber, you know, a bit stuck. Red, I don't have any policies or procedures for that. Then when you come to nursing, health assessments, green is, yep, everything's on a set schedule, it's just happening. Amber, sort of. Red, haven't really got anything happening there. Triage, green, yeah, all my calls are triaged for me. Amber, some are, some aren't. Red, don't have anything. Help, from a nursing point of view. Again, green, I get help on a regular basis. Amber, occasional. Red, I don't have any nursing help. And then admin side, green, yeah, I've got all my calls are screened for me. Front office. And I have a face to my presence. Amber, occasional or not really. Red, not at all. Back office, so things like admin support, practice management, those types of things. Green, yep, solid, I'm really happy. Amber, no, it's a bit sticky. And red, I don't have that function. And then effectiveness is probably around optimization of your time, use of the Medicare rebates that Imran will be talking about after. So green, yep, got that. Amber, stuck. And red, not really. So score those and just pop in into the question box where you stand. So are you mainly green? Are you mainly amber? Are you mainly red? Be good to hear. Out of those 9, are you mainly green, amber, or red? And so The point of this is that if you are experiencing any difficulties with how you're working, you can start to see those areas that are red or amber are probably areas that you want to work on improving, so that your experience of working in aged care improves. So I'll switch the camera off and just go back to my last slide.
So mostly amber responses.
Cool.
For most areas. So everybody's got something going, but I guess there's room for improvement.
Cool. Thank you. Thank you. So what next? Well, aged care is not doom and gloom. And my big thing is that I think we've probably been doing it a disservice at times by the language we've put around it. As Narelle said, we're looking at the most vulnerable people in society. And one of our callings in our profession is to really try and make a tangible difference for those people. And whilst we could get lost in doom and gloom, I firmly believe that it's really important that we actually, and we have a moral obligation to improve this. And each of us that are working in aged care, yes, it can be done better, but our job is to extol the virtues of it. It's when done right, it's really satisfying and great work, making a difference to many people, not just the residents, but also to their families at a very important time in life. If you're working in aged care already, have a look at the blueprint and see what's missing or could be better for you, like we just said. And if you're thinking about aged care and considering about working in aged care, then before you do it, really important just to think about, and that's a framework that I shared with you, to think about how you might approach the work. Now, what I'd like to encourage you is, if you're considering it, or if you're already working in aged care and you want some help or ideas around how to move yourself from red to amber or amber to green, then you've got my email address there, sachin@agedcaregp.com. Just give me a shout. I'll do my best to, in some way, shape or form, help you. And let's, try and make things better for these residents again, and for our colleagues who work in aged care, because they do a damn good job, and it's not easy, especially when they may not always have the backup that they need from us in the medical profession. So let's remember we're a team, and let's work together to make things that much better, for not just for each other, but for the people we're privileged to care for. Thanks.
Thank you, Sachin. And I will now move on to the next section quickly so that we don't run out of time for questions. This is probably some of the nitty-gritty and a bit boring part of the talk, which I will do. And there's a lot of text here, but I think it was important because I took these out of the MBS website. So I didn't want to edit them in any way so that I present accurate information. So as many of you who currently work in aged care may know, that on the 1st of March, there were a number of new MBS item numbers introduced, and all the old ones were made obsolete. There is now a new call-out item number that applies when you visit a facility for the first time, and it's billable only for the first patients seen at the visit. It can only be used once for the visit that you're doing, and it cannot be claimed by any other practitioners apart from GPs. On a practical level, for most vocationally registered GPs, I've just highlighted there in red the numbers that you would be using. These are the new numbers, and on the side panel there in the first column are the ones that they replace. Essentially, there's no difference apart from the fact that there's now a call-out fee, and the adjustment has been made compared to the old numbers to compensate for that. So we've done some calculations behind the scenes, and now works out that if you're seeing, I think the number was 17, if you're seeing more than 17 people per facility per visit, then you're about, well, you're a little bit better off by a few dollars, less than $5, I think. But if you're seeing more than 17 people per facility per visit, then you're a little bit worse off. And that's the number crunching behind the scenes. It's intended as a one-off payment to reimburse for travel expenses. This is according to the MBS. This is not my information. But if you have to return to the facility on the same day and it's not a continuation of the earlier episode, you can't use another call-out fee. But if it's a new issue for for the same person, then you can do it again. On some of the forums, people have been asking, oh, if I do a morning shift and then I do an evening shift and I go for lunch in between, can I put a new call-out fee? The answer is no. That's fairly clear on the MBS descriptors and, sorry, not the descriptor, but on the additional information on the MBS online website. The other question I've often come across is, can you use a call-out fee twice if you're seeing DVA and non-DVA patients because the insurer is supposedly different? The answer to that is also no. It's regardless of DVA or non-DVA patients, you can only use the call-out fee once. If there are 2 or more facilities located adjacent to each other, you cannot use the call-out fee twice, unfortunately, and you cannot bill the call-out items when you're using an additional existing derived fee, such as telehealth services or after-hours item numbers, and you cannot also use them when you're billing an urgent after-hours item. The bulk billing items obviously only apply to the attendance items. And you cannot use a bulk billing item with the call-out fee item. I've also put a quick slide in here to show some of the other item numbers that can be used in the after hours period. I've highlighted them in red to make it easier for you. This is fairly self-explanatory and straightforward if you do some aged care visits, and I won't go into this in too much more detail. It's just to give you an easy way to look it up. Apart from the normal attendance item numbers, I just looked at the last 6 months of the work I do. What other items can be used for the work that you do? These are some of the things that you can use while you're working in nursing homes and aged care work, and the corresponding item numbers depending on the time spent doing these things and the duration intervals, the recommended duration intervals between the number of times you can do this. You can look these up individually on the MBS online search function on the website. I came across a document a few months ago that is quite handy, and I think I'm going to try and speak to some of the facility managers. I've already started doing that. Many facilities already have something like this, and I think it's a handy little summary document to keep at the front of every resident's file. It is a good conversation starter, and it's also a very good record keeping device to make it easier for the facility, the family, the resident and the staff and yourself to work out when you're looking after someone, what is it that you're trying to achieve and what are the aims and goals of care for that individual person. This has been a really useful tool for me when discussing matters with family members, and I think I would be keen on trying to use something like this more. You can easily find this online. This is, you can come up with your own if you wish, but I think this is something worth considering. Finally, I wanted to remind everybody that when you work in aged care, it can be a very lonely experience as a GP. It doesn't have to be. There are a number of other service providers that you can call upon to lighten the workload for you. The residential inReach service, which tends to be available more in urban settings, and when I used to work in a rural practice in New South Wales, we didn't have anything like that. We had to do it all. So I understand that that's a lot harder. But in the urban settings, the hospital has a residential inReach service staffed by geriatricians who provide a lot of support and help when the problems become a little more complicated than what you can handle. And they usually are very good in attending within a day or two to help you with the problems. The basics service are a very good group of clinicians and psychiatrists and geriatricians that work together to deal with a lot of psychiatric and behavioral issues. But I cannot stress the importance of involving other providers to lighten your load in doing the job that you do. I also made a little quick list of handy apps and calculators, and also some forums that can be useful if you're doing this type of work and you need some help. You can search these on Google Play or the App Store on your iPhone to give you some advice and ways to calculate numbers and things that you may want. There's a couple of forums where you can you can get help from colleagues who are doing this type of work. Share GP through the RSCGP website, and also the Doctors in Aged Care Facebook group, where they have a few doctors doing this sort of work who can give each other some tips and advice. Some of you have asked where the Goals of Care document can be found. I know there's a copy of it on that Doctors in Aged Care Facebook group, so you can find it there. So I think that'll be the end of the formal presentation. We have about 10-15 minutes to go through some questions, and I shall just look at our list here. The first one that I think might be worth covering was regarding osteoporosis management. It was to Kelly, and the question was, why is daily dosing better than, say, 50,000 units a month?
Great question. There was some evidence that the higher doses were showing toxicity, but what were those toxicities? I don't have on the tip of my tongue, but I can report back. But there was some negative, just maybe in the last 12 months, there was an article that came out, and I have to admit I didn't actually read it. I just took the punchline because I haven't done the
So the summary of that is you feel that 1,000 units a day is a better way to manage the problem.
Yeah, well, the other one is once a week. It was okay as well. It was more the higher doses.
So there is an Ostelin specialist range brand that is 7,000 units supposedly once a week, and that's probably equivalent to
that would be my maximum. Yeah.
Okay. There is another question about osteoporosis management. Is there any benefit from being on denosumab and still taking calcium and vitamin D?
Yes, I think you need those building blocks if you're going to have something that's pulling it into the bones.
So essentially the denosumab would be the actual treatment for the osteoporosis, but you'd still need the calcium and the vitamin D on hand to allow you to do the job that the denosumab is going to do.
Yeah, and it is important to check that the vitamin D is okay before you give denosumab, otherwise you'll get side effects.
And would you also be checking calcium before and after you give denosumab every time, or just the first and second time?
Just the first and second time, but I do know that some people do it every time.
Okay. Now I had someone who, I guess this is an organizational matter, but the gist of it is that sometimes, and so Narelle might be a good person to answer this question, that people having falls and the sequence of events, and it feels like a buck passing exercise where someone falls, it has to be reported, the GP comes and sees the person. This particular questioner felt that at their facility it was automatically happened that the ambulance is called, the patient's taken to hospital, they find nothing, they're sent back, and they were just getting frustrated with this ongoing merry-go-round of passing the responsibility to the next
person. Yeah, and you're quite right. That is very much organisational. I know for the most part, and that's the other reason why I have very clinically based staff manning my facility 24/7, because those assessments are done at site. The only reason that we would send somebody to hospital is if they were presenting with all those symptoms of a fracture, such as shortening rotation and all that other stuff. The other thing that we will look at as well is for anybody that is on an anticoagulant. Then we would probably look at our organisational policies to hospitalise those, especially if their coma scales and their neuro-obs are not looking too great. Other than that, we basically notify our GPs. Generally, again, if we think that they're vitally stable and clinically stable and they are on an anticoagulant, we might get a locum in that instance to keep them in the home if that's in their best interest to stay in the home. So there's really no reason, if you've got good clinical assessments happening at the site, that you need to trundle people off to hospital unnecessarily. And it really goes to the confidence in the people in the facility, the practitioners, and the relationships they have with the GP and family.
Thank you. I agree with that 100%. I guess it depends on the facility and the confidence and the experience of the staff you have as to how that plays out. What I think the next question would be a practical one. We had two guesses for the game. It was FireSafe and Paperboy.
Yeah, Paperboy.
Paperboy.
So you got a bottle of wine.
Jeremy Nunes has won a bottle of wine.
Yeah. Just has to. I don't know how he's going to let us know where to send it.
One of the complaints was that doctors were having the frustration of double recording of notes, and Sachin, I think you and I have had this argument or debate about it a long time. What's your view on having to? Sometimes it's even triple, and you end up handing over to the nurse, writing in the facilities record, and then also having to record it on your own computer, and all of that is time consuming, for which you're arguably not getting paid for. And that's one of the reasons why GPs get frustrated with this job.
100%. So you'll notice when I was talking about the blueprint, I said it has to be wrapped in tech. Without doubt, one of the single biggest efficiency breakers and deal breakers for GPs is this duplication. It is an issue. What I would say is, first of all, from a risk point of view, especially a Medicare compliance risk, I think it's really important that we definitely hold our own set of notes in addition to the facility. I think that goes without saying. All I can speak about is how we're going about tackling it. We're through my organisation, we're pretty close, probably only a very short while away from being able to integrate our notes into several of the aged care softwares. So our GPs will type in best practice as normal, and then that will make its way to several of the aged care softwares. I think the other thing is that most software that we have isn't quite workflow-wise suited for the aged care workflow, and that can be a frustration for GPs because it just doesn't suit what we do in an aged care facility. Again, we're trying to solve that, but it's not easy. A year in the making, and we've got something now that allows that part to be a bit smoother for doctors, but still, that still needs to talk to existing, best practice or whatever software people use. But I think that tech piece is the key to make it more attractive and more efficient. Because for a doctor who's, high value work, it's extremely low value work to be copy and pasting. It's just low value work. We shouldn't have to be doing it, especially in this day and age.
All right, thank you. One question came in about with the recent issues in with managing difficult behaviours in aged care facilities. Are there any new guidelines about the use of antipsychotics or medications to sedate patients in such difficult situations?
Do you want to take that, or do you want me to?
Oh, if you're offering.
Look, I think any sort of guidelines around psychotropic medication is very stringent. I think you need to have a very clear purpose as to why you're prescribing it, and you certainly need to have a corresponding diagnosis. I think that if somebody's calling out, there's no medicine that will ever fix that, and you need to be looking at the triggers and the reasons, and as you said earlier, looking at the non-pharmacological interventions. Basically, long-term use of psychotropics is looked very poorly on, especially by our regulatory bodies, and we're looking at 3 monthly reviews now, and we've set up, there's a lot of issues around chemical restraint and that. Providing you have a corresponding diagnosis and you're using it for the purpose that it's designed, it doesn't necessarily constitute restraint. However, it needs to be reviewed regularly, and if there's no change and people need to have a trial off the medication, and if the behaviour basically dissipates, then there's no reason. And as we mentioned earlier, with the extrapyramidal side effects, if your risperidone is causing someone to walk sideways down the hall and fall over every 5 minutes, then it no longer serves its purpose. So I don't know if you want to add anything else.
Yeah, and just, I guess, documenting whether it is useful or not, because I think it's tempting to write that risperidone will work, but when you actually verbally ask people, it's like, oh, well, it helps like 5%. And so that's not really the end answer for that particular problem. Yeah, but just regular reviews as well. It is tricky because there's so much negative publicity around it all. But I think it's also useful to know that that's not your only tool, and there's lots of other medications that you can be trying to see if they can help as well.
And not to avoid it, I think that they all have their place and their purpose. I personally am very adversarial about PRN psychotropics. I find that some GPs sometimes want to put on things like PRN risperidone. We all know that it takes 2 weeks for the drug to hit the system and do anything. So as a short-acting drug, it, in my opinion, completely useless, and you're better off looking at your benzos and things like that.
Okay, I think we've just hit our time limit. There are a few more questions, but I'm afraid we don't have the time to cover them all. We've had a couple of requests for another webinar to cover some more ground if possible in the future, particularly there was one request here for about medical legal challenges in aged care. We'll take that on board, and I think I'd just like to thank everyone for joining us. There were over 200 attendees, and I'm sure a lot more will look at this webinar when we upload it later. Unfortunately, there won't be a text version. The video will be available, and you can view it at your leisure once it's uploaded in the coming week or two. Thank you for attending, and a big thank you to all the presenters.